Welcome to the monthly podcast presented by JAMA Health Forum. I'm Dr. John Ayanian, the director of the Institute for Healthcare Policy and Innovation at the University of Michigan and the editor of JAMA Health Forum.
And I'm Dr. Melinda Buntin, Bloomberg Distinguished Professor of Health Policy and Economics at Johns Hopkins University and the deputy editor of JAMA Health Forum.
JAMA Health Forum is a peer-reviewed, open-access, online journal focused on health policy, healthcare systems, and population health, and one of 12 specialty journals in the JAMA network. Our podcast each month presents highlights of new content from the journal, including timely interviews with authors of research studies and commentaries. Follow us on jamahealthforum.com, on Apple Podcasts, or wherever you get your multimedia, and on jamanetworkaudio.com.
Our guest authors today are Dr. Sherry Glied, Dean of New York University's Robert F. Wagner Graduate School of Public Service, and Ms. Dong Ding, who is an associate research scientist there. They're the senior author and lead author of a new study in JAMA Health Forum titled Healthcare-Related Savings Accounts, Healthcare Expenditures, and Tax Expenditures. Welcome to both of you.
Thank you.
Thanks for having us.
Sherry, please tell us about the genesis of this particular study.
So I've been interested in the tax treatment of health insurance for a long time. It's the principal public policy intervention that we have around employer-sponsored health insurance. And one feature of it that hasn't gotten as much attention as it might is health-related savings accounts. About 1 in 5 employed people with health insurance has a tax-related savings account, like a flexible spending account, that's an FSA, or a health savings account, an HSA. And there's been some research on what the effects of these things are on healthcare expenditures at different times, but they haven't really been done in an up-to-date, and they haven't really been done in a comprehensive fashion that really looks not only at the direct tax expenditure associated with the savings account itself, but the overall effect it has on premiums and expenditures. So we were really interested in looking at what the effect of these HSAs and FSAs are on healthcare spending and on the federal budget.
Yeah, so we found that really interesting. But for all of our listeners, can you tell us what a tax expenditure is?
Sure. We think about tax policy in terms of the taxes that people have to pay, say, on their wages. Sometimes the federal government will, or a state government will put into place a provision that exempts some sort of activity from taxation. The foregone tax revenues that they would have gotten if that behavior had continued to be subject to taxation are called tax expenditures. So it is the taxes that the government doesn't collect because it has put into place this policy. And so that's an important aspect of the federal budget. And tax expenditures for employer-sponsored health insurance broadly are a big element of total tax expenditures.
And those tax expenditures amount to a lot of money, don't they, Sherry? It's about $300 billion per year.
I think that's right.
Sherry, thanks for that clear explanation of tax expenditures that were part of your study. Don, can you briefly summarize the data that you used and the outcomes you focused on in this study?
Sure. As Sherry mentioned earlier, the goal of this study was to estimate the association between holding a tax-favored account and people's healthcare spending and their related tax expenditures. We compared these outcomes among the U.S. families that are covered by employer-sponsored insurance and who also hold an FSA or an HSA or none of these accounts. So we used the data, which is a family-level data from the Medical Expenditure Panel Survey, or the MAPS, from 2011 through 2019. And this is a survey that is collected every year by the Agency for Healthcare Research and Quality. MAPS is a nationally representative survey that provides very detailed and comprehensive information on healthcare expenditures, insurance coverage, as well as demographic and social economic information among the U.S. families. And what's most critical for us is that this survey also provides information on whether a family hold an HSA or an FSA, or how much money, which is the pre-tax money, they put into this account to cover their out-of-pocket expenses. And we also use the tax model, which is developed by the National Bureau of Economic Research, to estimate each family's marginal tax rates based on the information provided in MAPS. And then we use this marginal tax rate to calculate the tax expenditures of each family based on their premiums and out-of-pocket expenses.
Thank you, Dong. Can I ask you also to summarize the main findings of your study?
Yeah, sure. There are three major findings in this study, and I would like to start with families holding flexible spending accounts. We found that these families spend on average 20% or $2,000 more on healthcare annually than do families without any accounts. And this big difference was largely driven by the higher insurance paid expenses. Previous research, including the formal estimates by the Joint Tax Committee, they mainly focused on the tax expenditures that are directly generated by this account, or say the tax expenditures on the tax sheltered contributions. But what we found in this study is that the bigger effect of FSAs is that they lead to a much higher insurance paid spending and therefore a higher premium, which is also tax excluded in most scenarios. And this means that holding an FSA is actually associated with a higher extra tax expenditure than previously estimated. And specifically, we estimate this number is about $1,300 per family per year. And then when we move to the families holding house saving accounts, we found that they had the highest out-of-pocket expenditures. And compared to those non-account holders, HSA holding families spend on healthcare from their out-of-pocket is nearly 50% higher, but their insurance paid expenditure on the other side are insignificantly higher. So the overall house expenditures of these families are similar to those of non-account holders. But in terms of tax expenditures, holding an HSA is associated with nearly $900 in extra tax expenditures because of the higher tax advantaged or tax sheltered out-of-pocket spending. And we did not see any significant reduction through their premium savings. So the overall association is insignificantly positive. And this is quite surprising because the expectation when designing HSAs was that although they would increase the tax expenditures on the out-of-pocket side, but due to the low premiums and the requirement of the high deductible policy, their overall effect on tax expenditures would be negative, which is the opposite of what we observed. And finally, when it comes to types of services, we found that both types of accounts are associated with significant increases in tax expenditures from additional ambulatory services and dental visits and vision care. And these are the kinds of services that are most sensitive to cost sharing.
Sherry, following on that summary of the findings from Dong, what do you see as the implications of your study for policymakers, for clinicians, and for the public who may or may not have access to these flexible spending and health savings accounts?
So I think there are a few policy implications. One is, people went into the idea of these accounts in the hope that by incentivizing people to buy higher deductible plans, by giving them the opportunity to shelter the upfront money in an account, people would choose higher deductible plans, they would spend less money, and we would have sort of a win-win situation. We find there is not a win-win situation. At best, there is a lose-nothing situation. So FSAs seem like a total loser, and HSAs seem like, at best, they have a neutral effect, right? So there's lots of interest in expanding the scope of these accounts, in increasing the participation in these accounts. I think our results suggest that's probably not a good way to go if you're trying to control healthcare spending. And I just want to point out that kind of makes sense because what we know from lots of research in health economics is that people are really sensitive to first dollar coverage. That front end coverage is really where cost sharing has its bite. And these savings accounts really protect people from that front end coverage, from the cost of the initial utilization of services. So it's not that surprising that what they lead to is a lot higher spending overall. That is sort of the thing that you might expect to see. And with the HSAs, that is offset to some extent by the higher deductible, but apparently not enough. So I think the first policy recommendation is, look, recognize that if you expand these things, they have a substantial cost, not just the direct cost on the federal budget of the savings accounts themselves, but the fact that they induced higher health spending. So you should recognize both those elements as you think of expanding the use of these or changing the way that they can be used. The second thing is a fifth of people with employer-sponsored insurance have them, but that means that 4/5 of people do not have them. And I think there are two kinds of inequities that arise from that. One is inequities between employees of firms that offer them and those that don't, where, you're just not getting the benefit. I think in some ways that the even more serious one is between people who work at a firm and don't have one of these accounts when the firm does offer it. Because in those cases, the premiums are going up for everyone, but they're going up because the people with accounts are spending more money. And those people we don't know yet, are probably richer, more likely to be white, more likely to have higher educations. So there's a big disparity that's potentially created and exacerbated by these accounts.
So that's important information, I think, for the policy community, but also for employers and people who potentially are eligible for these accounts, what effect it's having on both their own costs as well as those of the government. So really interesting findings that I think our readers and listeners will want to dive deeply into. Dong and Sherry, at the end of our podcast interviews, we like to ask a couple of questions of our guest authors. And Dong, I'll pose the first one to you. What's the best advice you've been given about your career, particularly for developing policy-relevant research, such as your article with Professor Glied in JAMA Health Forum?
Yeah, thanks for the question, John. The first thing that comes to mind is actually from my co-author and my mentor, Dr. Sherry Glied, who is here with me today, because she always reminds me that the descriptive studies are also incredibly powerful. And it's okay that we can't always draw causal conclusions in our research in policy studies, but to ensure the robustness and the reliability of our descriptive results, we still want to do numerous sensitivity analysis and other approaches to try to test the potential bias and try to eliminate any bias from our descriptive results.
That's really great advice, as usual, from Sherry, and especially important for JAMA Health Forum, where we publish a really wide variety of policy relevant studies, including well-done descriptive ones like yours. So, Sherry, I'll ask you our other question for all of our interviewees, which is, what is the biggest change you expect over the next 5 years related to health policy?
So that's a tough question, especially as we run into a presidential election season. But I'm going to make a big assumption, which is that whatever happens, we're going to continue along the ACA path. That is, we're not going to roll back the coverage expansions that have already happened, and we're going to maintain and even build on that and have more people covered. And I hope, so this is not what I think will happen, which is a little harder, but what I hope will happen is that we will actually start to think about the U.S. healthcare system as if it were a universal health insurance system, which is not the way we've thought about it until now. Up until now in our history, we've had always a substantial share of people who are uninsured, and a lot of the structure, the policy structure of our healthcare system has been built around that premise. So we have all these special programs, special facilities, and so on that are built around this notion that there are people who will not be able to have financial access to care, and they won't be able to get care. And, we've now had the ACA expansions in place for 10 years. I think it's time for us to start thinking about that system in a new way and saying, what should a system in which coverage is the way we pay for everything? What should that look like? I guess the second thing I'd say, Melinda, is that I'm struck by the fact, and you know this too, that healthcare costs have not been growing as quickly as they used to. And we don't totally get what's going on there either. I think we all, as economists, need to think about it. But again, how do we think about our system if cost containment has a different form than it has until now?
So on that optimistic note, I'd like to thank our guest authors, Dr. Sherry Glied and Ms. Dong Ding of New York University. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.